normal histology of the glomes, what are the variety of the glomerular diseases, then pathophysiology of glomerular injury. After that, how to approach the glomerular disease, and there are some terminology: nephritic syndrome, nephrotic syndrome. Then how to investigate these patients or laboratory workup. Obviously, after workup, we have to manage this patient. So, as you know, this nephron, picture of the nephron, it is the basic anatomical or structural and functional unit of the kidney. It is composed of Bowman capsule, proximal convoluted tubule, this is a picture, loop of Henle, and the distal convoluted tubule. These are the parts of the nephron. If you discuss regarding the blood supply, there are two vessels, the afferent and efferent. Afferent means supply, efferent when blood away from that. The blood to be filtered and enter the Bowman capsule via the afferent arterioles, and it leaves the capsule via efferent. Efferent means away, afferent towards. So what is the glomes? Basically, glomes is the tuft of the capillaries. The efferent arteriole form a blood network called the vasa recta that reabsorb components of the filtrate from the nephron. This slide shows the glomerulus under light microscope, histology of the glomes. Basically, already told you, this is the vascular structure, comprise tuft of the capillaries. It is a tuft of the capillaries which are arising from the afferent arterioles to form the lobules, and that rejoin the vascular pole of the drain into the efferent arteriole. Mesangium, each lobule is supported. Vesical mesangium is the supporting structure that support the lobules. This tuft, talk regarding the basement membrane. This is the tuft lies within the lumen of the expanded proximal end of the nephron, which is lined by the epithelial cell overlying thick basement membrane. GBM, glomerular basement membrane, has got three layers. Trilaminar, tri means three, structure. Lamina rara externa, it is the external layer. Lamina rara densa, it is the central layer, and lamina rara interna is the internal layer. So there are the three layers of the glomerular basement membrane. Sometimes they will ask you in the MCQ regarding these layers, and the size of the glomes is 200 micrometers. Well, what is the term hypercellularity? Presence of more than 3 cells in the individual glomerular mesangial region, that is called hypercellularity. Same slide, histology of glomes. Glomerular capillary wall, already told you, 70 to 100 nanometer, and glomerular basement membrane, visceral epithelial cell, and mesangial cells. Basically, these are capillaries. This is the ultra microscopic structure of the glomerular capillaries. If you see the outer portion, that is the brown portion, this is epithelial cells, and this green portion that is surrounded by the oval shape, it is called basement membrane, and inner yellow portion is endothelial cells, and mesangial cells. Already told you, these are supporting. Mesangial cells support these capillaries. Coming to the glomerular disease, basically glomerular nephritis can be defined as a spectrum of renal disease of varied etiology and clinical presentation. that are characterized by clinical and histological evidence of glomerular damage. This damage manifested by an inflammatory process. GN, glomerulonephritis, is recognized and the second commonest cause of the chronic kidney disease worldwide as well as in the Pakistan. In developed countries, it is still the third commonest cause of end-stage renal disease in many countries. So these glomerular disease accounts for significant proportion of the kidney disease, because major portion of the kidney disease belongs to the glomerular disease. There are many causes of glomerular disease that are related immunological and non-immunological causes, inherited disease, and deposition of proteins such as amyloid in the glomeruli. Most patients with the glomerular disease do not present acutely and are asymptomatic. Sometimes abnormalities are, but routinely, if you do the urine analysis, that shows the proteinuria or hematuria, so we must suspect this patient is suffering from the glomerular disease. Now coming to the pathogenesis of glomerular injury. Pathogenesis of glomerular injury involve a complex of that interplay between the genetic factors like congenital nephrotic syndrome. Congenital nephrotic syndrome usually occur in less than 1 year of the children, and acquired immune and non-immune factors. Immune factors like cellular immunity, humoral immunity, there is complement system and cascade pathway that play important role in the pathogenesis of the glomerular injury. This is the pictorial presentation of the pathogenesis. Antibody mediated. If you see the in situ immune complex deposition, cytotoxic antibody cells mediated, so activation of alternative pathway and circulating immune complex mediated. So that interplay the pathogenesis of the glomerular disease. Coming to the clinico-pathological classification, there are two types, primary and secondary. In primary, glomeruli are the predominant site of the involvement. In secondary, there are certain systemic and hereditary disease which involve the glomes that are called secondary glomerular disease. So this slide shows the various causes of the primary and secondary glomerular disease. If you see the primary glomerular disease, minimal change, idiopathic, primary FSGS, IgA nephropathy, mesangiocapillary GN, acute post-streptococcal GN, anti-GBM disease. In secondary, diabetes, secondary FSGS, SLE, that is called lupus nephritis, or sometimes vasculitis, ANCA-associated anti-neutrophilic cytoplasmic antibody, that is called ANCA, secondary membranous GN, amyloidosis or cryoglobulinemia. This is the same slide that is already discussed. This is taken from the Robbins pathology book, glomerular disease, primary and systemic disease. Now the classification of glomerular disease by distribution. Either one glomes involved or many glomes are involved. There are two terminology. Focal, only small glomeruli are involved. If suppose so many glomes are involved, among them 40% involved, that is called focal, and diffuse means affecting most or all part of the glomes, means whole glomes are involved. When single gloom is considered, the terminology is used, segmental or global. Segmental means lesion involving only a part of glomeruli, and global means involve the entire glomes. Are you understanding? So after this clinic classification of glomerular disease, now the clinical evaluation of the glomerular disease depends upon the history play important role in the diagnosis of the glomerular disease. Any disease, history is very important to detect renal problem or other disorders. After that, we have to examine the patient. After examination, we should investigate the patient to confirm the disease. So these patients can present with various clinical manifestations. They can present with the nephrotic syndrome that is characterized by proteinuria more than 3.5 gram in 24 hours, hypoalbuminemia less than 2.5 gram per deciliter albumin, and hyperlipidemia. So nephritic syndrome, proteinuria, but it is non-nephrotic range. These patients can present usually with hypertension, and hematuria is also present in nephritic syndrome. Rapidly progressive GN, RPGN, acute nephritis, proteinuria or acute kidney injury. CKD, they can present with azotemia, progressive to uremia over months, years, sometimes isolated urinary abnormalities, glomerular hematuria or subnephrotic proteinuria. This table shows the common glomerular disease presenting as a nephritic syndrome. The difference between nephrotic and nephritic is that nephrotic syndrome characterized by proteinuria and hyperlipidemia and hypoproteinemia, but in nephritic syndrome usually present with proteinuria but less degree of proteinuria, and hematuria and hypertension is the characteristic feature of the nephritic syndrome. So there are certain diseases in children post streptococcal GN after pharyngitis, tonsillitis or skin infection. So if you do the serological test, ASO titer will be raised. Other post-infectious disease, endocarditis, if you auscultate the patient, cardiac murmur will present. In serology, complement will be low, C3 and C4. And in case of shunt, which are usually done in case of hydrocephalus, that's BP shunt or shunt nephritis. So patient can present with a low complement C3 and blood culture may be positive. IgA nephropathy can present with upper respiratory or GI infection. In serology, serum IgA will be raised. When SLE involves the kidney, that is called lupus nephritis. So other manifest multisystemic features of lupus may be present. Here in SLE, serology is ANA and WC DNA should be positive, or sometime in few percentage WC DNA not present, but ANA is 100% present. And C3 and C4 should be low in case of lupus nephritis. Now, how to approach these patients, when to suspect glomerular disease, how to categorize the glomerular disease, etiology of this categorize either primary or secondary. That etiology already discussed. Complete the diagnostic arc by means of the history, physical examination and investigation, treatment and follow-up. So when you suspect the glomerular disease, history is very important. These patients can present with edema, hypertension, foamy urine. Foamy urine suggestive of proteins in the urine. Change in the weight, they can present weight gain, family history of renal diseases, smoking as important also etiological factors, recent infection, throat infection, skin infection, or respiratory infection, drugs, so many drugs, NSAID, non-steroid and anti-inflammatory drugs, penicillamine, gold, lot of drugs can cause also these glomulopathies. Other systemic illness and malignancy. After that, we have to examine the patient to see the edema, pitting edema is present, ankle edema. Then these patients gave the history of the in the morning facial puffiness of the face, blood pressure. If you check the blood pressure should be raised, and if these patients can present severe hypoproteinemia, the nails become white. That is called leukocythemia. But in case of the CKD, if they have developed, that is called brown nails. That is called brown nails. This is a significant feature of the CKD. Xanthelasmia, deposition of the protein, palpable purpura sometime in case of vasculitis, and ascites may be present in this patient. As far as characterization of the glomerular disease, that are divided anatomical, glomerular or non-glomerular, physiological, we should check the renal function, clinical diagnosis, it is nephrotic or nephritic. Then histopathological diagnosis by doing the renal biopsy, proliferation, crescentic immunofluorescence. Etiological diagnosis, either primary or secondary. Laboratory, we should check the protein level, autoimmune profile and complement level. So this slide shows the investigations. Urine analysis is very important. Already discussed in the previous lecture. We have to check the proteinuria, hematuria. We should quantify the proteinuria by, there are two methods of the quantification of proteinuria. One is the 24-hour urinary collection of the protein. Other is spot urinary protein creatinine ratio. Then presence of the dysmorphic RBC, that is suggestive of glomerular disease. Dysmorphic means change in the shape of the RBC. Serum albumin should be checked because albumin is low in this patient. Lipid profile is disturbed in the nephrotic syndrome. Electrolyte abnormality may occur. Bone profile means calcium, phosphorus, alkaline phosphatase. In lupus serology, already discussed ANA, WC, DNA, complement levels, RF factors, anti-GBM antibody like Goodpaster syndrome, post-streptococcal GNA ASO titer, vasculitis, ANCA profile. There are two types of ANCA, C-ANCA and P-ANCA. Serum protein electrophoresis should be done to rule out the multiple myeloma. Viral marker has got important part because hepatitis B, hepatitis C and HIV also cause glomerular disease, and sometimes diabetic patient also present with these problems. Ultrasound is very important to see the size of the kidney, parenchyma of the kidney, stones or hydronephrosis, because before doing the renal biopsy, ultrasound is mandatory. This slide is Sam already discussed regarding the investigation, assessment of renal function by doing the urea, creatinine, electrolyte, urine analysis to see the proteins, serological test. Okay. Imaging, ultrasound is very important. Also the kidney size, renal size is of normal, and GM Sometimes kidneys are large in certain disease like amyloid, HIV nephropathy, or diabetic kidney, or an acute GN. Small kidney and echogenic kidney suggestive of chronic kidney disease. Renal biopsy has got important role because the aim of doing the renal biopsy is one. There are three aims of renal biopsy. One is that to confirm the histological lesion. Second, to make the management plan. Third, predict the prognosis of the patient, because there are variety of glomerular disease, glomerular lesion. Each lesion has got own prognosis. After doing the renal biopsy, we are more wiser to do the counseling regarding the glomerular disease, because family can ask you regarding the after doing the renal biopsy, आपने डॉक्टर साहब ये बायोप्सी तो की लेकिन इसकी प्रोग्नोसिस क्या है, प्रोग्नोसिस बताएं. सो बायोप्सी की हैज़ गॉट very important role to predict the glomerular disease. This picture shows as this child is suffering from the nephrotic or nephritic syndrome, because his face is swollen and periorbital puffiness. If you see the legs, both legs are swelling. You should see the ankle edema or extension of the edema. It depends upon the nature of the disease. And these are the brown lines, which are the Band's line, nephrotic syndrome, and xanthelassemia also present in case of nephritic syndrome. After diagnosis and presentation of the patient, therapeutic approach is very important. Therapeutic approach is the lifestyle modification, dietary modification, low salt diet, low protein diet, fluid restriction, because these patients can present with edema. So we should not ask them or encourage the more water. Treat the edema by restriction of the fluid and diuretics. If the patient is suffering from blood pressure, give him antihypertensive, especially ACE inhibitor or ARBs. If the patient is diabetic, control of diabetes, suffering from uremia, correct the uremia. Immunosuppressive drugs have got important role like corticosteroid, azathioprine, and cyclosporin. So these drugs has got the important role. There are certain complications of the nephrotic syndrome. We should prevent and treat the complication like deep vein thrombosis, renal vein thrombosis, or infections. So we should treat that. This is the last slide. So already discussed general measures regarding diet, weight, and low protein diet. Normal recommendation of protein is 1 gram per kilogram per day, but in case of the nephrotic syndrome, these patients are losing the proteins, so we should decrease the protein 0.6 to 0.8 gram per day plus aid the urinary losses. In previous days, there was the concept to give the patients more proteins because he is losing the protein. Nowadays, research suggests if you give the more protein, there is the glomerular injury. So that is the reason we should restrict the proteins. Normally 1 gram per kilogram per day, but in these patients 0.6 to 0.8 gram per kg per day. Low salt diet, maximum up to 2 gram per day. Regular exercise. If the patient is a smoker, he should avoid the smoking. Water intake already told you. If the patient has got edema, we should decrease the water intake, should control the blood pressure, reduce proteinuria by ACE inhibitor, ARBs, and other immunosuppressive drugs. Control edema by restricting the restriction of the oral fluids and diuretics. So this is regarding the all the how to approach the glomerular diseases, because there are the variety of the glomerular diseases